Hello, everybody. Welcome back to the Incubator Podcast live from the CHNC Symposium in Denver, Colorado. We are joined by Dr. Mehul Raval, who is a professor of surgery and pediatrics at the Anne and Robert Lurie Children's Hospital of Chicago. Mehul, thank you so much for dropping by.
Oh, it's my pleasure.
You had a very interesting talk this morning, quite very well-attended talk titled Building Towards Enhanced Neonatal Surgical Recovery. I think this is something that is a very interesting topic because we tend to not think too much about that beyond the immediate postoperative period. Like if our patients do well in the immediate 12, 24 hours, we're like, we dodged, everything went well. Yeah. But I think this was a very interesting topic. And so for the people who didn't really have the chance to attend, can you tell us a little bit about what you were trying to leave the audience with?
Yeah, absolutely. I think it really starts with understanding the concept of an enhanced recovery protocol. And one of the things I talked about was how surgery is actually quite traumatic and can really induce a lot of physiologic derangement and stress. And it just takes time for the body to recover from surgery, from this controlled trauma. And what the concept of enhanced recovery really addresses is how we can speed up or enhance that recovery time and get people back to their baseline or maybe to an enhanced state. And we've done this for years and years in adult populations and even in pediatric populations now, adolescents and young adults, et cetera. And I think the next big opportunity really is with our neonates and infants undergoing surgery. And to take it one step further, it's not about any one specific intervention. It's a multiple component bundle that you're trying to implement that really allows you to take on some of the things that I think are quite dogmatic, especially in places like the NICU, and challenge those paradigms and have us think outside the box about how we can better optimize these infants. And my hope is that we can, demonstrate some improved outcomes.
And it's not just this theory of enhanced recovery, tissue recovery. It's reducing complications and length of stay. So tell us a little bit about that data.
Yeah, so the most profound data comes out of the adult literature, where across the board, when people have implemented enhanced recovery protocols, they've been able to demonstrate a 2 to 3 day reduction in length of stay, a decrease in complications by about a third. And overall just improved patient satisfaction. We've been able to actually recapitulate that in the pediatric population, and maybe not with as many dramatic outcomes, but definitely a slight improvement in length of stay, and most dramatically, decrease in opioid utilization in our adolescent population. Similar things I think we could expect for the neonates and infants undergoing surgery. A lot of advanced feeding protocols and other bundles that have been implemented in neonates in the past haven't always necessarily changed the overall length of stay. Right. But some of the indicators are out there that you could initiate feeds a little faster than maybe we traditionally do and maybe get to goal feeds faster. And so I'm actually very interested in thinking about alternative outcomes of interest. Things like, can we get to enteral feeds sooner so that we can get rid of central lines and decrease CLABSI rates and things along those lines? And so there's some real opportunities out there.
Yeah, you mentioned in the talk one of the consensus guidelines for perioperative care in neonatal intestinal surgery with enhanced recovery after surgery society recommendations. I think you touched on a few of these guidelines, including nutrition. There's some very interesting points there. Really maximizing parental involvement. I think it's something that's coming up a lot. But what's so interesting to me is how this idea of enhanced recovery has led surgical teams to even think about the intraoperative period and saying, how do we actually operate on these infants? How do we tailor the care we're delivering in the operating room in order to maximize recovery? Can you tell us a little bit about that? That's so interesting.
Absolutely. So you mentioned at the very start that we consider a surgery a success if the first 12 and 24 hours go well, right? And I actually think that that's where concepts like enhanced recovery bundles kind of tear down the silos of the phases of care and really allow us to look at things as more of a continuity of care type of paradigm. There are absolutely things we could be doing preoperatively, like using non-opioid analgesics and loading the patients, like using regional blocks, like setting expectations with families and caregivers about the process that will help better care for the patients in the operating room.
Yeah.
In the operating room, there's absolutely things we could be doing on the anesthesia side to limit our IV fluid utilization, which decreases swelling, and limiting our perioperative fasting periods, which decreases our fluid requirements in the operating room, and even thinking about surgical techniques that might be different. Really pushing forward for minimally invasive techniques whenever possible, even in the neonatal population, and also considering the actions that we're taking. If you have a distal ileal atresia, trying your best to do a primary anastomosis rather than creating a stoma and a mucus fistula and then dealing with the issues and complications that can occur when you have those types of things happening. And so being thoughtful about it, and then once again, bringing it full circle to the postoperative period. How are we managing pain? Do we have a plan where we've involved the anesthesia teams, the neonatal teams, the surgical teams, to all come together and say, what's our strategy for managing postoperative pain? What's our expectations for getting these patients out of the incubator and into the parents' arms for skin-to-skin care and things like that? Just being really thoughtful about making sure everyone's aligned.
And I think what's interesting about it is that you do not need to take everything at once. I think a lot of these interventions are quite low-hanging fruits, one of them being, so for example, better control and better monitoring of temperature intra, pre, and post-operatively. These are very easy for institutions to take on since all the equipment's already there, and it's just implementing that. And to that end, you mentioned a lot of your experiences in implementing these protocols, these guidelines, talked about implementation science. Can you tell us a little bit about how to set the expectations when these projects want to be rolled out or adopted by different hospitals?
Yeah, I think that's really the challenge. That's where the rubber meets the road, is how do we take these concepts that we would all agree are not just acceptable, but should be the standard of care, and how do we make sure that every patient is getting them every single time? Yeah. And some of the elements are what I would consider more of a horizontal integration, meaning every baby that goes to the operating room, we should be doing everything that we can to maintain normothermia, for example, right? And so a horizontal integration across the entire NICU population is probably advisable for that element. There are other elements that are going to be very procedure specific or patient specific. And for those, you have to think more of like a vertical integration type of approach. And I think that there's two key components to that. Number one is actually collecting the data. Yeah. We oftentimes think that we are doing some of the elements, but then when we really measure it and assess it, we find out that we're not as good as we think we are, right?
So true.
And then the second thing is, I think, the necessity for collaboration. Yep. Any of these diagnoses that we try to vertically integrate on, there's no one center that has the volume necessary to really be able to demonstrate improved outcomes. Yeah. And so we're going to have to use collaboratives like the CHNC and many others to kind of bring folks together to collect these data across our institutions and really learn the lessons that need to be learned in order to once again, deliver that care on a day-to-day basis.
Awesome.
I love that you specifically have talked a few times about communication, all being on the same page. Something that we're working on in our unit are these transitions to care, our handoffs. How can we support the surgical and anesthetic teams as the neonatal in-unit team, especially, I think, during these periods of transition and exchange of information?
Yeah, and I think that there's been a tremendous amount of literature to support the importance of that communication and these handoffs. Not just in the NICU, but throughout healthcare. Sure. I think that there's some basic strategies that I think folks already know, but things like using checklists, believe it or not, at key interval periods in time, including in handoff period, can be very helpful. I think that setting clear expectations about a pre-op handoff or a post-op handoff, who needs to be present, who are going to be the key players, what is the key information as it relates to an enhanced recovery protocol that need to be communicated so that we're all on the same page. We don't have all those things fleshed out. We don't have all the answers, but I think that in general, the data support doing these types of interventions, and I think that the complexity and the acuity of our patients require it.
I love that.
Mehul, thank you so much for dropping by and for sharing the great tidbits and tenets of the presentation that you gave today, and best of luck on this work and on the ongoing QIN trial that you have going on.
Thanks a lot.
Thank
Happy
you so
to be
much.
here.
Bye-bye.